Good afternoon, colleagues, and welcome to this industry-sponsored symposium, Navigating the Evolving Landscape of Endometrial Cancer. I'm Dr. Kathleen Moore from the Stevenson Cancer Center. I'm excited to be the moderator today. Thank you all for joining us. I know this is the last day of the meeting, and many are getting ready to leave to fly back across the country after this exciting 3 days, so we appreciate you spending an hour with us this afternoon. And please go to the last session so we can support our speakers at the end. All right, I'm gonna just kind of go through here. All right. So we're gonna begin with speaker introductions. I've already introduced myself. I'd like to just have my panel introduce themselves.
I'm Linda Duska. I'm a G1 oncologist at the University of Virginia in Charlottesville.
Hi, I'm Scott Jordan from Broward Health, G1 oncologist in Fort Lauderdale.
Welcome. These are our disclosures, and they're available online. We are going to be talking about a lot of off-label utilization of medications today, including the use of Selinexor in endometrial cancer. It's currently still investigational. It is not approved by any regulatory authority, just as a reminder. This is a view of our objectives for the day. We're going to have sort of 3 modules. The first, Dr. Duska is going to take us through understanding endometrial cancer landscape and the role of molecular profiling. And then Dr. Jordan's going to take us through the mechanism of action and some of the data for use of nuclear export proteins, Selinexor, in endometrial cancer. And then we're going to do some cases and have some fun just sort of talking through how molecularly complex endometrial cancer. I think it's always been complex, we just didn't know it. So now that we know it, the treatment selection has become a little bit more challenging. So we're gonna go through some cases and discuss how we might approach the therapy for each of our respective patients. This is our agenda. We're gonna try and stay on time and have you out right at 1:30 so you can get to the next final session of SGO. And so with that, I'm going to turn it over to Dr. Duska.
I was told that I'm supposed to tell everybody that I was Scary Spice last night. My fellows volunteered me to be Scary Spice, which I actually thought was extremely appropriate. I've been told I can be terrifying. Thank you all for staying and for coming to our session today. I get the easy job. I'm going to talk to you about something that hopefully everybody in this room already knows a whole lot about, which is the problem that is becoming endometrial cancer in our country, and what molecular profiling looks like and what hopefully we're all doing in our practices at this point. So we all know that endometrial cancer is the most common of the uterine cancers, and of course when we talk about uterine cancer, we're including other types of cancer besides just endometrial cancer. But endometrial cancer itself composes 90% of, uterine cancer, 90% of them occur in the endometrium, as we know. What's also important to know is that while solid tumors in general have been decreasing over time, we've seen a rise in endometrial cancer, and this, interestingly, is particular to high-income countries. And in particular, in North America and Western Europe, we've seen the highest disease burden and the biggest increase in disease burden. And this is likely attributed to lifestyle issues such as obesity that we're seeing particularly in the United States. In fact, many of you likely know that there's a linear relationship between obesity and endometrial cancer. With a relative risk of I wrote them down so I wouldn't forget them, 1.5 for those who are overweight, and this goes all the way up to a relative risk of 7 for class 3 obesity. So clearly in this country where we have a significant issue with obesity, we're also seeing significant rises in endometrial cancer. There's also an independent association with endometrial cancer and diabetes. So it's a huge problem, no pun intended. And we're seeing more and more cases in the United States, particularly where I live, where there's in the South, Mid-Atlantic area, where there's a lot of obesity. You can see on this slide, uterine cancer is the 4th most common type of cancer in women in the United States. You can see close to 70,000 new cases. Compared that to ovarian cancer, which is much, much lower, obviously, and 13,000 deaths. And we're going to get back to the rising rates in a moment. Over on the right is something people in this room are also very familiar with. The majority of cases are diagnosed when they're still confined to the corpus, which is fortunate and which is also why the relative survival rates are generally better in endometrial cancer than they are for, say, ovarian cancer. But if you look at the yellowish, greenish bars in the bottom right-hand side of the slide, the overall survival, the relative 5-year survival for distant metastases is very low. And so there's clearly an unmet need here. Also, you would see the same for recurrent disease. So this slide is a little bit outdated. I haven't been able to find more updated data like this. These are data from the United States. And on the left, you can see the rate of uterine cancer per 100,000 women. The overall line is yellow. So the yellow line represents an overall, you can see a rise in incidence of uterine cancer. But also, if you would focus on the blue line, the rate of incidence in Black women, the slope of that line is much steeper. So we're seeing a very significant increase in Black women as well as Hispanic and Pacific Islander women than we are for white women. So white women still have the highest incidence, but it's not increasing at the same rate. We're seeing a disparity. And we're seeing an even worse disparity in the United States when we look at the rate of uterine cancer deaths, which is on the right-hand side. And in particular, that line up at the top. Black women are much more likely to die of their disease, and the rate of mortality is significantly increasing with Black women. What's really interesting to me, because I live in a very rural area of the country, is that we're also seeing geographic, rural versus urban, and socioeconomic disparities affecting endometrial cancer incidence and mortality. Diagnosis at late cancer stage and reduced survival are more common in those individuals with lower socioeconomic status, lower median household income, and access to healthcare coverage. So this is definitely a significant problem in the United States. When we're talking about Black women, we know that they are more likely to have a high-risk histology. They're also more likely to have a higher stage of endometrial cancer at the time of diagnosis. But in addition to that, they're more likely to have worse outcomes at every stage, grade, and histology. And interestingly, at least in the US, they're less likely to receive chemotherapy and radiation. So we definitely have work to do in this area. This is something that many of us are very passionate about, is to try and improve equity with respect to cancer treatment in the United States. This is a slide, so there are some slides that I saw about 100 times this meeting, not this one, but the next few I'm going to show you. This is a TCGA slide. It's on the relative old side, it's 2013, but just to remind you, the TCGA looked at a little less than 400 cases of endometrial cancer and developed this, something now that we're very familiar with, molecular classification of endometrial cancer. So over on the left, you see the POLE ultramutated and the MSI hypermutated. Those are the so-called hot tumors, although my T-cell researchers tell me we're not supposed to call them hot anymore. But anyway, be that as it may, those are the hot tumors. And then over on the right-hand side, the copy number low and the copy number high, or serous-like tumors, are the so-called cold tumors. And this molecular classification led to the PROMISE algorithm, as many of you know, where we're looking at POLE, microsatellite unstable, and then these copy number high and copy number low groups based on p53 mutations. We're going to get back to that in a minute. And the progression-free survival curves that you see over on the right come from the very nice paper from Doug Levine published in Nature, where you can see that these molecular subtypes are very predictive of prognosis. Where the patients with POLE tumors seem to do very well, the patients with copy number high or serous-like tumors tend to do very poorly, and then the copy number low and microsatellite hypermutated tumors are somewhere in the middle there. So this is one way to think about categorizing endometrial cancer based on histology and molecular testing. Now, many of us in this room probably are not doing POLE testing. I know at my practice we are not routinely doing POLE testing, but those are going to be the minority of the tumors depending on the population that you're looking at. Maybe about 5 to 6% of tumors will be poly-mute. So if you start over on the right-hand side of the slide with MMRD, MMRP, and start there, about 25 to 35% of tumors will be MMRD positive. And then for the MMRPs, we can divide those into the P53 mutant and the P53 wild type, and those are the NSMP tumor group. If you think about how we're doing this, though, what happens is the NSMP group becomes a diagnosis of exclusion. So they're not poly, they're not MMRD, they're not P53 mutant, and therefore they're everything else that's left over. And I think it's really important to understand that point because a lot of tumors are going to fit into this category. So your endometrioid grade 1 and grade 2s are going to fit into this category, but so are your mesonephric-like tumors, and so are your clear cell tumors. And so this is a mixed bag of tumors that I think, we can talk about this later, but that I think deserve further study, and putting them all in the same category might not be fair. One way people have thought about differentiating these is by looking at hormone receptors, for example, and the NSMP tumors that do not express estrogen receptors are the ones that are going to behave poorly, and that's something that we've talked a lot at this meeting about. The other thing that's not included in this schema, but that we'll talk about later, is where you put the HER2 testing and which tumors you test for HER2. Somebody told me that they test all tumors for HER2. Well, I think you could, that's reasonable, but I think you could also make the argument to only test certain subtypes for HER2 because not all of them are going to, some of them are very less likely to express HER2. So we've had some really amazing changes in the treatment landscape for endometrial cancer since 2021, and I had to write them down for myself so I wouldn't get them confused. So in 2021, we got approval for dostarlimab as a single agent for recurrent or advanced endometrial cancer that was dMMR. And then in March 20, that was based on the Garnett study, which I was very fortunate to have open at my site. I loved the Garnett study. Then in March of 22, we had Keynote 158, which got approval for pembrolizumab, again, as a single agent advanced advanced or recurrent endometrial cancer that was MMRD, who progressed following prior systemic therapy. Sorry, that was the same for 2021. Whoops, going backwards. And then in 2023 in 2023, based on the RUBY data, dostarlimab got approval in combination with chemotherapy in the upfront setting for MMRD tumors. This was shortly followed in 2024 by approval for all tumors for both pembrolizumab and dostarlimab in this setting. And then, of course, durvalumab also received approval in this combination. So lots of options here. This is kind of a strange way to look at this data, but these are all of the studies, GY018, DUO-E, RUBY, and ATTEND, that looked at these induction chemotherapy followed by maintenance with a PD-1 inhibitor, and it's divided into the hazard ratios for dMMR versus pMMR. And I think the important point here is to note that the hazard ratios are much lower for the dMMR group. So the dMMR group does much better than the pMMR group with this, with an IO in combination with chemotherapy followed by an IO maintenance strategy. And those of you who have been at this meeting with me the past few days may have seen this slide about 100 times. But I think for me, this slide is really informative for a lot of reasons, and I really love this. These are hypothesis-generating subgroup analyses from RUBY. So over on the left upper corner is poly. There were far too few patients in poly to even talk about poly, very, very few. And then across from that, in the bottom right, you see the NSMP category. Now, there were about 400, a little more than 400 cases for which they were able to do this molecular subtyping. The NSMP group was 220 something. So again, the NSMP group represented more than 50% of the cases on RUBY. But when you look at the curves in the lower right-hand corner, I hope you can see The hazard ratio is 0.77, but it is not statistically significant. Again, this is hypothesis generating. Ruby was not powered to answer this question. But you can see that the NSMP group did not benefit from the addition of dostarlimab at all. That's not true for the p53 mutant group or for the DMMR group. It may or may not be true for POLI. We can't tell because there are just too few patients in that group to answer that question. But I like this slide to also make the point that in the NSMP tumors comprise, depending again on which population we're looking at, remember we're looking at advanced or recurrent endometrial cancer here, more than 50% of this group. And yet, they don't seem to benefit from the addition of IO. So this slide is very busy and has a lot of really small print, and so you can I believe that you'll be able to download it at the end, but these are select phase 3 studies evaluating targeted therapies for endometrial cancer, ranging from early stage endometrial cancer and serous and carcinosarcomas to advanced and recurrent endometrial cancer, thinking about strategies for how we might be able to target these particular molecular subgroups. And I think the most important thing to take home from this is that we have learned that it is very, very important to try and study particular molecular subgroups and to power our trials to answer questions specific to molecular subgroups. We need to split rather than lump if we're going to be able to answer questions about targeted therapies. So I hope I've convinced you that endometrial cancer is an unmet need. As we see rising cases, we also see that advanced or recurrent endometrial cancer has a poor prognosis, and I don't think we can expect the particular NSMP group to respond well to IO strategies. There are limited maintenance therapy options to delay disease recurrence or progression, and this NSMP group is a particular group that we need to think about how we're going to manage moving forward.
So there's microphones around the room if people wanted to. We've heard a lot at this meeting about the evolving molecular characterization of endometrial cancer, and so we actually have a little bit of time if you had questions and wanted to come to the microphone. I can just start by building a little bit on what you talked about. Can you pull back up that slide?
Yeah. Tell me when.
Right there.
Okay.
So this is the kind of the TCGA classification that we've been talking about for over a decade, and you mentioned a couple things that will layer onto this, and one of them is the assessment of HER2. Mm-hmm. HER2 IHC, I think, is what I'm particularly talking about here, rather than amplification, although that's still something under discussion. So can you just maybe talk a little bit further around how you see like this graphic evolving over time? Is there going to be like another layer, and it's going to be DMMR, HER2, TP53, HER2 positive, NSMP, 2+3+1+? Like how do you see HER2 layering in here?
Yeah, so I think we're learning, particularly from the data that we have in serous cancers, that HER2 is very, very important to test early on. So yes, I think it needs to layer in, maybe even in the integrated diagnosis line, that we need to be thinking about it. And I also already alluded to, I can't say this enough, I think testing for hormone receptors, ER and PR, is really important, particularly in the NSMP group. But also I think it's important because we often forget that hormones and hormone combinations offer opportunities for our patients that are less toxic than some of these things that we've been talking about. So I would probably layer in HER2. I would also layer in hormone receptors. And then as we learn more about things like ARID1A and CCNE1, I think we need to start layering all those other things in too. So it's going to become more and more complex as we learn more. The other thing that I forgot to mention, but I think is really important to mention, is that this type of molecular profiling is much more reproducible and predictable of prognosis than the traditional histology and the traditional type 1 and type 2 tumors that we are used to, those of us that are old, are used to. And in fact, the grade 3 endometrioid tumors about 20% of those will be P53 mute. So I think it's really important to keep all of that in perspective and make this a priority in your practice.
And then you brought up, can you advance to the Ruby subset analysis by histology? And you brought up sort of the suggestion of differential benefit in the mismatch repair proficient of immune checkpoint inhibitors. And the Ruby data that you're showing here was the first glimpse of this that we saw. I see you. Dr. Eskander has promised me that we're going to see 018 in the near future, so I'm pretty excited about that.
Too.
And then we showed Duo-E, Shannon, and then I repeated it at this meeting. And there seems to be some, we'll see what Ramez's data shows, Dr. Eskander, sorry. But there seems to be some inconsistency around the TP53 ascertainment and how important whole exome versus next gen, like what's the, when you say get TP53, what are we talking about?
Well, sorry, thank you. So we're talking about IHC, and I think actually that's fascinating because it's true for her too also, right?
Yeah, absolutely.
So it really depends on whether you look at next generation sequencing or you're looking at IHC, and it depends on whether you're looking at amplifications or which mutations you're looking at. And it gets so complex. I feel like we're just scratching the surface of it at the moment. IHC is definitely not perfect. It depends on which part of the tumor you're looking at. I think NGS is gives you more accurate information, but then I'm not sure we're quite at a place yet where we know what to do with it.
Yeah, it's still a lot to learn. So the message is don't make decisions based on subgroups just yet. I see a question at the microphone, please.
Yes, Abraham from Colombia. In the non-specific molecular type, what's the value of the receptor or estrogen receptor positive or estrogen receptor negative? Is it of clinical value right now? Is it different when the estrogen receptor is positive or negative?
So there's some relatively recent data that suggests that the ER negative NSMPs are the ones that are at highest risk for recurrence. Now, do we have data that suggests that you should act on that? No, not yet. But I often will discharge a patient from my practice after 2 years with an early stage NSMP tumor to follow with her regular gynecologist. But an ER negative one, a patient with an ER negative tumor, I might choose to follow her more closely because I know she's at higher risk. But do I know that doing something then is going to solve the problem? I do not.
And I don't think we have any data that says ER 50%, ER 75%.
Thank you.
You know, what's negative.
Right. We
You
don't.
know.
Thank you for bringing that up. We have no idea how to quantify HR. We just, and ER in particular, some old GOG studies have looked at quantifying PR, but we don't have, and maybe a little ER, but I don't think we agree on how to quantify
Right.
ER.
Which is why it really hasn't been built in as an integral biomarker for selection for a lot of clinical trials because of the sort of heterogeneity around how it's assessed, and we can't agree, even though it seems really easy, just pick ER. Nothing's ever as easy as it seems.
Right.
I see one question in the back, and then we'll go to Dr. Jordan. Yes.
What do you think about the possible research also of the PD-L1 expression in endometrial cancer? So as the Ruby sub-analysis has shown, maybe there's also, like in the TP53, a large cohort of patients who can benefit of the ICE monotherapy instead of maybe like Pembro plus Lenva because they express PD-L1, and there's a lot of translational studies that has proven that.
I don't personally love PD-L1 as a biomarker for endometrial cancer or frankly for cervical cancer either, but I'm interested in what my co-presenters think.
Yeah, I'd agree with that. I don't know that we have anything that definitively shows that PD-L1 is a great marker for response for IO and endometrial. And like you said, even cervical, it's like, eh.
Yeah.
Yeah, we did in Duo-E, when Dr. Weston first presented the data, we did show the PD-L1 and PD-L1 negative subgroup, but it wasn't analytic, and so I think that may have confused some of the issue around it being predictive of response. And in the recurrent setting, in the proficient mismatch repair populations, remember when we were doing all those single-arm phase 2s and really the drug didn't work, they were selecting, a few of them selected by PD-L1 positive endometrial cancer, and it really had no predictive benefit. That being said, there's at least 4 different assays for PD-L1, and the scoring differs, between them. So when we talk about PD-L1 positivity even, it's like ER, we're not even talking in a common language yet. But I agree, I wouldn't be using it to select patients in this setting. Yeah, disappointing, I know, we're not lung cancer. Okay, we're gonna move on, right on time. So I'll turn it over to Dr. Jordan. Do you wanna present from there?
Oh,
Or do you wanna sit?
Yeah, I don't want to break the trend, so I'll present from
we
here.
like sitting.
We're all tired.
So, yeah, like I said, I'm Scott Jordan from Broward Health. I'm a GYN oncologist. Elephant in the room first, just so everybody can concentrate on endometrial cancer. It's a proximal humerus fracture. Skiing in Italy in the Alps. Yeah, I got airlifted. Yeah, I delayed my surgery for my ORIF so I could be here with my ortho's blessing. And I can't probably operate for like 3 months, so I'm going to be annoying the GOG about trying to get more trials for my site during that time while I'm not in the OR. But a huge honor to be here with 2 of the giants in our field. So thank you to the GOG and Karyopharm for thinking of me and including me in this discussion. Very much honored to be here. So I get the privilege to talk about Selinexor and like kind of where we've been, where we've come from, specifically with respect to Selinexor in TP53 wild type endometrial cancer. And if you don't know the mechanism of action of Selinexor, it's actually pretty cool. If you think about what TP53 does in the nucleus when it's functioning, is it is a tumor suppressor gene. So there's this molecule, XPO1, that carries it out of the nucleus, prevents it from functioning when it's not mutated. Obviously, in our mutated cancers, this is a different mechanism, but in TP53 wild type cancers, where it should be functioning, it's being carried out of the nucleus by XPO1, and what Selinexor does is prevents XPO1 from carrying it out of the nucleus, leaving it in the nucleus, where it can function and lead to apoptosis in cell cycle when there are issues with DNA. And so it can actually function as a tumor suppressor like it's supposed to. And so here's some of the preclinical data showing that with Selinexor, you can see a greater concentration of P53 within the nucleus where it's supposed to be, where it's working. You can see it with immunofluorescence and then also IHC in different disease sites. Selinexor has been used in multiple myeloma, so that's a nice picture of increased P53 staining in the nucleus with Selinexor treatment. And it's important, like Dr. Duska said, P53 wild-type tumors account for about 75% of newly diagnosed and about 50% of advanced recurrent endometrial. And remember, that's P53 wild-type specific. That's not NSMP, so there's some crossover with all those groups, depending on how you're defining your subgroups there, the molecular subgroups. So when the GOG first and Karyopharm first looked at Selinexor, it was the Endo trial, and what they included was females with stage 4 or first recurrence of endometrial cancer. So advanced recurrent endometrial cancer, they had to have gotten 12 weeks of taxane carboplatin doublet. They could have gotten prior surgery, radiation, or hormones in the past. And they had to have had a PR or CR by RECIST criteria before enrollment. This was a maintenance trial. They were enrolled, randomized 2-to-1 to receive Selinexor at 80 or 60, depending on weight. And that's weekly oral drug versus placebo. And the primary endpoint was investigator-assessed progression-free survival with those secondary endpoints you can see there. We'll talk about OS and PFS2 and some of those other secondary endpoints in a minute. And then the predefined exploratory endpoints, this is like kind of the meat of the data that we'll get to soon, was the subgroup analysis, the molecular subclassification. So while the entire intent to treat population was the primary endpoint for the PFS, the exploratory endpoints included P53 mutation status, MMR status, and POLE status. I think that's all I wanted to hit there. So inclusion criteria, we talked about a little bit there. One important note here, as Dr. Duska was talking about with the with NSMP kind of being this catch-all, last time you had a clear cell and you sent your NGS report, they're P53 wild type a lot of times. Clear cell was excluded from the SIENDO study. Despite being P53 wild type, because there's a lot of other stuff going on there. So this is endometrioid serous, undifferentiated, and also carcinosarcoma. They had to have gotten at least 12 weeks of platinum doublet with taxane with PR, as I said, and then they needed to start study drug about 5 to 8 weeks after completion of the final dose of chemo. And again, important to note, because this was a maintenance trial, the PFS measurements actually started at that point when they got randomized, not when they started their treatment. They were not allowed to have had previous anti-PD-1 or PD-L1 immunotherapy on the SIENDO trial, which is of note, and that's, I think, a function of the times, because this was before this was standard of care in a lot of our frontline patients. So this was the disposition. Selinexor, as you can see, 2-to-1 randomization, so the Selinexor group was twice the size. 75 patients discontinued due to disease progression. 18 patients discontinued due to toxicity. And then 15 withdrew by the patient. And at the end of the study, about 120 versus 65 were still on trial. About 51 had discontinued, and these are pretty much 2-to-1 all the way down. So this is the intent to treat endpoint. I think this is a really interesting, for me as like a younger investigator and learning about trial design and trying to think about how we move things forward, move the needle in treatment of our diseases, and how thinking about designing the trial is actually going to impact your ability to do that. I think it's a very interesting story that this trial was designed with an intent to treat population and a post hoc subgroup, pre-planned subgroup analysis afterwards, rather than P53, just taking the P53 wild type patients. And so when you lumped everybody together, excellent example of why we're not supposed to lump, the median PFS was not statistically significant. It was a negative trial. You can see that all the way down, the PFS2, TFST, TSST, and the PFS at all the endpoints were not statistically significant. But when we looked at the P53 group, and this is just a little background on the P53 group, these are pretty equally split groups. I don't think there was any big disparities between these two groups. This is the P53 wild type subgroup. And again, this is not NSMP. We're going to get to that in a sec. But this is P53 wild type, median PFS of 28.4 versus 5.2 months. So this is like a really big deal. But again, it was non-analytical. Nobody said Rob Coleman yet in this room. So I've heard him in every other, anytime statistics come up in every other room. So I'll be the first one to say, Rob's not here, so I have to say, this is subgroup analysis, non-analytical, it's hypothesis generating, and it was an exploratory endpoint. But still very, very exciting for our P53 wild type patients. And even more exciting, For 2 years now, we've known exactly what to do with that group on the right, the DMMR patients. So, yeah, I mean, they had an improvement, but even more exciting to see this in the PMMR P53 wild type subgroup, to see a 39.5, I think, right? Versus 4.9 months.
I don't know how you can see that.
I think I just remember because I tell my patients, I have this slide for my patients when I'm trying to talk to them about the trial. 39.5 versus 4.9 months median PFS with a hazard ratio of 0.2. Is that what that says? Yeah. It's better up. 0.36. Still fantastic. I mean, these are numbers in the neighborhood of like the stuff we get really excited about, like Solo 1, like Ruby, like these trials that are huge practice-changing trials. A hazard ratio like that, but again, it's exploratory subgroup analysis. The study wasn't powered to answer this question, so we can't change practice based on this. But still very, very exciting, hypothesis generating, and we're going to talk about the testing of that hypothesis here in a minute. So when we look at, so that was PFS obviously, when we look at preliminary OS, and the study closed in January of this year. So again, exploratory endpoint, exploratory subgroup analysis. But I want to call your attention to that PMMR, P53 wild type, NSMP type group, that they didn't reach median PFS at 38.5 months of follow-up. And you can look at the confidence interval is 45.4 to not reached, with a median number of recurrences not reached. They had only had 25% of patients with events at 38.5 months. So this is a little bit of a small, kind of immature data set, but these patients seem to do really well in these subgroups. Adverse events. We always like to talk about the exciting stuff of how this is going to benefit the patients, and then we've got to talk about the sort of like the stuff that then we have to deal with and the phone calls we're going to get about the drug. Nausea is a big deal. It's an oral drug. It is sometimes tough to control. It can be pretty devastating, but once you've got a little bit of experience with the drug, you can. It's doable. It's not insurmountable, and I think it's in counseling of patients and how you can explain to them what to expect, so that they're expecting some nausea, they're expecting vomiting, they're expecting that, yeah, you might have these things. We're going to try and prevent them, but we've got other things that we can escalate the anti-emesis protocol if we need to. Diarrhea, and you can see grade 3 is not too high in any of these. So neutropenia, 20% grade 3. But in general, these were less than grade 3. So they're things that you can kind of get over with supportive care, counseling, and a lot of times, like I've done, is showing the patient again that PFS potential advantage from the preliminary data. So busy slide, a lot of words. But the Endo trial, remember, it was negative in the intent to treat population for advanced or recurrent endometrial cancer. Intent to treat, that was all comers. But in the P53 wild type subgroups, in a non-analytical exploratory endpoint fashion, we saw a hypothesis generating signal that there's a potential massive PFS benefit of 39 versus 4.9 months. So that's huge for these patients where, you know, these aren't the patients, just like Dr. Duska showed that group, these aren't the patients that are deriving a ton of benefit, if any, from IO. And important to note that that's also hypothesis generating and non-analytical. But if we kind of take all this together and take the entire clinical picture, these are patients that maybe we don't have that magic bullet that we all thought we had a couple years ago for all of our advanced endometrial cancer patients. We needed something else for these patients, and this is very, very promising. With that, turn it over to Dr. Moore to talk about how we're going to test that hypothesis.
We have 5 minutes for questions. Boy, I'm going down quickly here. Whew. All right, 3 days of meetings taking my voice out. Okay. We do have 5 minutes for questions before my part, so if you have questions, please come to the microphone again. Let's just talk a little bit about SIENDO really quickly. So the SIENDO study was actually a positive study. You know, the ITT was statistically positive. It was just felt to be sort of clinically not impactful because of the DMMR inclusion of the inclusion of the TP53 mutated. Is that correct?
It was, so hang on here. I want to make sure I'm getting all my statistics correct. The hazard ratio for the intent to treat was 0.76 and it crossed 1, the confidence
It
interval.
wasn't statistical,
Yeah.
okay. But it looked a little
0.54
bit-
to 1.08.
Okay, but the subset analysis that showed this kind of market improvement was in this kind of TP53 wild type population. So is that, and we'll kind of harken back to the discussion with Dr. Deska, and I'm looking at the demographics in the TP53 wild type subgroup. It looks like 80 to 84% were endometrioid tumors. So TP53 endometrioid. So are we presuming that these are all kind of no specific mutation profile, of course, because they are TP53 wild type? Is there any sense that molecularly that there's any difference, like what you were bringing up earlier, Linda, estrogen receptor positive versus estrogen receptor negative, ARID1A, beta-catenin? Are there any other molecular drivers of response to Selinexor in this group that we've identified yet? Or is it just all TP53 wild type and endometrioid and we're good to go?
Well, I mean, I think it's important to note that only 70% of them were PMMR. So there were, even in the P53 wild type group, there were 30%, about 30% DMMR in both arms, and they were evenly split between the two arms. So they weren't in SMP. That's, I was trying to make that distinction of, they weren't in SMP. They were P53 wild type, but they may have, if you did that graph, the Ruby graph with this, they would have gone in. Those patients would have gone into the DMMR, not the NSMP arm, and then but the NSMP patients seemed to be the ones that had the most, the biggest advantage, because it was the PMMR patients compared to in the P53 wild type subgroup, the PMMR patients seemed to have the most benefit. But I don't think they looked at, I mean, I would imagine that most of those endometrioids would be ER positive.
ER
but
positive
we
just
don't
by
know.
statistics.
Yeah.
You know what, this makes me think of the Mirasol study,
Yeah.
right? Like, think about all the times that we've just not understood the importance of a particular biomarker, and then we do a study that looks negative, and then fortunately, somebody is smart enough to say, hey, let's do a subset analysis, and then the company says, hey, we're going to invest in another study, because thank you for doing that, by the way.
Yeah.
Because otherwise, we would be throwing away a drug that would really benefit people, because we just haven't looked at the right population.
That's such a good point. How often does that happen? Because we are very
It
fortunate
happens a lot.
with Immunogen. How often does it happen that they do the follow-up trial?
Right, exactly.
So-
And the follow-up trial costs a lot of money.
It does
They
cost a
do.
lot of money.
But
I was
you-
thinking about that today, or was it yesterday that Dr. Herzog presented weekly paclitaxel
Yes,
and the PIK3,
exactly.
and it was totally negative, except in that phospho-AKT
Yep.
subgroup. And I was like, are we going to follow up on that? Because that looked pretty different, but you'd have to prove it. So it is very fortunate that we
Exactly.
are going to, and I'll talk about that study in a
Yes,
second.
sorry, I didn't mean to steal your thunder.
No, no.
But it makes me, it's the same as the Forward One Mirasol
Yeah.
story. And I think, you know, because we don't design these trials well, most of the time because we don't really understand the complexities or the subtleties, we end up throwing away drugs that would really benefit our patients.
Yeah, it's a real commitment to coming back.
Yeah.
Yeah,
I mean, these studies are immensely expensive.
I think
Yes, they are
in
immensely.
retrospect, it's really easy to look back and be like, oh my gosh, why on earth would we have done it? Why would we have designed it this way? Or, you know, when we look at some of the other studies, like why didn't they have this arm or that arm? And with the biomarkers we know now, this study it started accruing in 2019. So, I mean, if you think back to to 2019, all we didn't have, everything that was on all those approvals that Dr. Duska talked about, I think you started, that line started in 2020, right, with dostarlimab. So that was even before we had, before 158, before Garnet. We didn't, you know, it's easy to look back now and be like, oh my gosh, why didn't we think of all this? But we didn't know any of that stuff then.
But you know, you also made me think, the person who asked the PD-L1 question made me think about the first Merck trial with pembrolizumab looked at PD-L1 to see if they could, PD-L1 predicted response to pembrolizumab, and it really didn't. And it wasn't until they looked at MMR status that they realized, oh, here's the biomarker. So we can recognize that you need a biomarker, but we also have to choose the right one.
Absolutely. And the biomarkers, you're right, Scott, we look back and we're like, well, you kind of kick yourself. It's like you armchair quarterback everything you do. Well, that was stupid. Why didn't we do this? But TP53, we talked about this a little bit. TP53 is not TP53.
No, it's not.
What are you calling? What's the call? What's the validated biomarker? Because if you'd done the wrong sort of test, you still could have had, a spurious outcome.
Yep.
So sometimes, we go a little bit fast sometimes to these studies, and the opportunity to do a redo is really, that's a great point.
And we're going to talk about the redo.
Yeah, let's talk about the redo. This is the redo. I feel like I'm well equipped to talk about redos since I've been here us all. So I'm going to take you through export. So export is currently enrolling and enrolling well, but we still want your help in getting this across the finish line. It's open really broadly. This is a nice map, and you can get that QR code if you're interested in knowing a little bit more about the trial. This takes you to the NCT number. But this is open at a lot of sites. I know that there's sort of a little bit of a missing geographic distribution where we are right now, and in the northwestern part of the United States, which is a little bit unfortunate, but the rest of the United States is very broadly covered. So this study really is accessible, hopefully, to patients with advanced recurrent endometrial cancer wherever they live. When we're talking about oral therapies, and especially endometrial cancer, Dr. Duskus took us through some of the epidemiology of this disease, our only solid tumor rising in incidence and mortality, making sure we have trials that are accessible to patients across the U.S. and not just at kind of our ivory tower academic centers is critically important. And so the fact that this is open so broadly and at many community sites like Scott's site is really important. And I was going to ask you earlier, we'll come back to it when I'm done. I want to ask you about, Scott's kind of one of our, if you're not the leading accruer,
I think
one of the leading accruers.
I made the newsletter. I thought I was the leading
You made the
accruer, but
newsletter, yeah.
I'm like two
Watch
or three.
out.
Yeah.
Watch
We
out.
all aspire to make the newsletter, yeah. So I think this is really a testament to the commitment to get the study done and also have it be really representative of the patients who are at risk of developing and dying from endometrial cancer. So I expect and hope that the demographics table for this trial will reflect that. This is the study. It's going to look very similar to what Dr. Jordan just took you through, with some notable exceptions that I'll take us through as we talk about this. But this is a randomized phase 3 study. It's double-blind of Selinexor as maintenance therapy again after response to platinum-based chemotherapy. It still enrolls patients with advanced stage 4 disease or first recurrent endometrial cancer, so that is still the same. They have to have received at least 12 weeks of platinum-based chemotherapy with a response before coming on. They have to have known TP53 wild-type disease, and that is by central testing, and we'll come back to that point. And new, not quite yet, but there's an amendment coming out that patients who are mismatch repair deficient but medically ineligible to receive immune checkpoint inhibitors can now be enrolled. And so that's an important, it's not quite ready for prime time yet. And I don't know that this is an enormous population, but it certainly is a population. And so these are going to be included in this schema moving forward. So that's the early eligibility. I'll take you through the I&E in another slide. Again, they have to have a partial complete response to therapy, and then they're randomized 1-to-1 to Selinexor 60, and I'll come back to that dose in a moment, orally once a week. until progression or toxicity, or 3 years. And, you know, we actually, I mean, it's kind of astonishing to think that we actually may have patients who finish that 3 years and come off NED. That's not a world that I have lived in until now, and it's exciting to be here as compared to the standard of care, which would be considered placebo. Primary endpoint is progression-free survival, currently in the ITT population, but it will be a modified ITT moving forward as we include the patients with mismatch repair deficient, but immunotherapy medically ineligible when the amendment goes through. With that amendment, the trial sample size did increase from 220 patients to 276 patients to ensure that the modified ITT population will include the 220 TP53 wild type proficient mismatch repair tumors, because that's the analytic endpoint. So we need to have enough of those to power the study. And then in addition, it will allow for the eligibility of patients who are medically not fit to receive an immune checkpoint inhibitor. And so again, this is in front of the regulatory authorities now. So this is the dose selection. You heard Dr. Jordan talk about the dose in Siendo, which I'm showing you here, which was 80 milligrams orally Q week versus placebo. We saw the outstanding results in the subset analyses, but he also took you through some of the challenges with using Selinexor in this space, and it was predominantly GI toxicities. So the most common treatment emergent adverse event, as you just heard, was nausea, with 80% of patients reporting nausea and 50% reporting emesis, and then we did see about a third, a little over a third, with thrombocytopenia. This resulted in about 50% of participating patients randomized to the Selinexor arm having a dose reduction compared to almost none, as you would expect in the placebo arm, and about 10% of patients discontinued Selinexor due to these treatment-related adverse events, mostly related to nausea and vomiting, which isn't in and of itself, when you think about patients discontinuing a therapy for reasons other than progression, 10% is not that high when you think about other medications that we use. However, when we're thinking about a medication that's being used in the maintenance therapy for 3 years, even having grade 2 nausea, sometimes even grade 1, is really disturbing, you know, for our patients. It's not good quality of life, and we want them to have good quality of life while they're living longer. And so even though the discontinuation rate, you may think that looks okay, just the fact that patients were that sick for the duration of their treatment resulted in kind of a deep dive into the dosing and what we call the exposure response analysis to figure out if we really needed to be at 80. And so that was done from the Siendo study. And because of the number of patients who had dose delays and dose discontinuations, this exposure response analysis suggested that Selinexor at 60 starting dose instead of 80 would likely be as effective, but also mitigate some of the toxicities. And, you know, if patients are able to stay on medications, the medications work. Medications don't work when patients don't take them. So this was really a very scientific and pragmatic decision to move a better tolerated and hopefully efficacious dose into this space. And so in the current study, the dose is 60 milligrams once a week versus placebo. And we'll talk about the dose management, or the adverse event management, which is here. Not dissimilar to a lot of the new medications we're using. I mean, if you've been to any of the presentations on antibody drug conjugates with exatecan or deruxtecan payloads, we are classifying these as highly emetogenic and recommending triple therapy right up front, and, you know, days of antiemetics after to really mitigate and prevent that toxicity. And it works. So we can use these medications to their best effort for patients while maintaining good quality of life. Same thing exists here with an oral regimen. This isn't a PARP inhibitor. And, you know, I think a lot of us, when we got our hands on this oral maintenance, we're like, oh, I know how to do this. It's not a PARP inhibitor. The emesis here is quite a bit more significant and needs a more kind of aggressive intervention and mitigation strategy to keep patients on treatment feeling good. The nice thing is that because this is weekly, we can be aggressive for that dose, and then patients aren't on like daily aggressive antiemetics like they would be if we needed this kind of intervention for a PARP inhibitor. So what you can see is there's sort of two options here that we offer, or that we suggest. One is a 5-HT3 receptor antagonist you can use on Dansitron, for example, every 8 hours before each dose, so each week, and then continue it maybe day 2 and 3 just to cover any delayed emesis. And you want to combine that with a neurokinin and NK1 receptor antagonist or a mixed serotonergic antagonist like a Prepotent. And you start that at the initiation of study drug and continue that for the first 2 cycles. And sometimes you can de-escalate this depending on how the patient's doing, just like we do in PARP inhibitors. You kind of maybe start with daily and then you can back it off after 6 or 8 weeks once patient's gotten accommodated to the dosing. And sometimes you just need to continue it so you can really individualize based on how the patient is tolerating things. Or you can use an NK1 receptor antagonist combination with 5-HT3, and the drug is called Akenzio. This is what we use at our site. My partner, Debbie Richardson, really is the study champion for this study at our site and really had to fight initially to get this drug approved on our pharmacy. So she was a really big advocate. And so this is what we use, and it works quite well, but it is expensive. And we can maybe talk about this in a moment because I see you nodding your head, Scott. Yeah. This is something you have to really pay attention to make sure patients have access to the drugs that work. So pre-screening, so this is a switch maintenance study. So there's pre-screening that can be done during chemotherapy when the patient's receiving paclitaxel and carboplatin. Many of you are going to have sent next generation sequencing, so you kind of know already that your patient is TP53 wild type. That's what we do. But you still have to submit central testing because this will be a companion diagnostic, what we call a CDX. And so that's being done through Foundation Medicine. So if you've done it and you're like, oh, good, I'm TP53 wild type, you can talk to your patient, consent them for pre-screening, and launch the testing. If, for whatever reason, your site's not doing next-generation sequencing in this setting, sometimes there's cost barriers, then you can still do central testing, just like you would in any other clinical trial. So you can do that during chemotherapy and know if your patient's eligible and start talking to them about it. Once they've completed chemo and they have a complete or partial response, then they can sign main consent, and they need to treat within 8 weeks of finishing chemotherapy. And so that window is kind of tight. It is, I'll remind you, close to what we did with all the PARP studies. We maybe had 9 weeks on some of them, but it is close. So we've done this before successfully, but you kind of have to be strategic as you have your patients treating on chemotherapy to have things ready to go and lined up. The TP53 central confirmation takes a couple weeks, so you don't want to use a couple of your 8 weeks to work on that. So get it done early. So you can sign consent. Screening assessments have to be performed within 14 days of randomization. It's very similar to most things. Most screening tests, CTs and stuff, can be within 28 days, and then labs and other things within 14 days, and then randomization occurs after eligibility has been confirmed. And then you're off to the races. These are the kind of more granular eligibility criteria. It's only open to adults. They have to have histologically confirmed endometrial cancer. So you do have to have a pathology report. It can't be based on cytology. TP53 wild type confirmed by central testing. In a moment, you'll be allowed to enroll patients who have TP53 wild type deficient mismatch repair tumors. So stay tuned for that as long as they're medically ineligible to receive an immune checkpoint inhibitor. They have to have completed one regimen of platinum-based chemotherapy. Now, they can have immunotherapy with the chemo. So if you've started that just right out of the gates while you're sending your next generation sequencing and kind of working the patient up, and midway through it comes back and they're TP53 wild type, you can use your immunotherapy with chemotherapy. That's not disqualifying. It just has to be stopped when they enroll to the clinical trial. It cannot be continued as maintenance. So that's something that I think people have been a little bit confused about. Again, it's primary stage 4 or at first relapse after primary therapy. those patients can come on good performance status and like all the other lab eligibility that you all know well. Uterine sarcomas are excluded. Carcinosarcomas are not excluded because they're not sarcomas. But so as long as they're TPH3 wild type, which a lot of them are not, but some of them may be, they're not excluded. But clear cells, small cell, neuroendocrine, those are excluded. And they're rarely TP53 wild type anyway. They have to have good bone marrow reserve. So if they've required a blood or platelet transfusion within the first 2 weeks of cycle 1, day 1, they're excluded. They need to be able to take their antiemetics. So you wouldn't be putting someone on anyway that couldn't tolerate oral medications. They can't have had a prior XPO1 inhibitor, which would be kind of unusual. They can't be showing evidence of progression, post-chemotherapy, and then they can't have had a major surgery within 14 days. These are all very standard things that I think you're well aware of. So that's the current study. And before we move on to the cases, I just wanted to turn to both my panelists, because I saw you nodding your head around the Akenzio kind of fight and the nausea. Can you just kind of take us through practically kind of how you've been really successful at both enrollment and also helping patients to maintain dosing with, with good quality of life. So what's the magic sauce here?
I don't know that there's, I don't think there's anything magic. I tell my patients that one of the worst things I can do to them as the treating physician is to like ruin their quality of life with nausea. Like from the beginning when I start carboplatin. So I'm aggressive always in trying to prevent nausea. But when we enrolled our first patient, we started with the prescribed regimen, and that didn't work. I added Zyprexa, that didn't work. We added steroids, that didn't work. And we went to the investigator meeting, and everybody was talking about, have you tried Akenzio? It's like, well, I don't know if we're going to be able to get it. So we had to battle with our pharmacy to actually like even stock it and provide it to the patient. But as soon as we got her on it, I mean, she was about to come off trial. After maximal dose reduction and everything with all these supportive meds, and as soon as we got her on it, she was like, no, I can do this. It's okay. So it's there in the back pocket. I wish we could just like start patients on it and try and prevent it from ever becoming an issue, and maybe even prevent some dose reduction, but it's there, and it works really well.
And how do you talk to your patients? Because there's such a momentum around chemo IO. Understandably, there's so many clinical trials, and there is statistically and I think clinically relevant improvement even in a PMMR. We're not curing people, but we certainly are helping them. So what's the kind of clinical equipoise around stopping immunotherapy in this TP53 wild type population and randomizing to Selinexor versus placebo? Like, what's that conversation look like between you and the patient?
I think that's tough. I mean, we talk about the data that's available, and I think it's a little bit easier because of the Ruby subgroup analysis to point out, look, if you're P53 wild type, if you're in that NSMP group, maybe you don't have the benefit that these other groups have that a P53 mutated patient may have. When we looked at the GY018, that showed the PMMR group with a advantage, and the all comers with an advantage. What was driving that, and is there a biomarker for driving that? And maybe it's P53. It's probably a lot more complex than that. But I think with that Ruby subgroup analysis, it kind of answered the question. We're like, yeah, the NSMP that's maybe the group that's not benefiting a whole lot, and maybe we don't know what we're doing down the line for Lin-Pem, and are we burning an IO bridge early on? I think there's a lot we don't know, but if I have a patient that's got an option to go on Selinexor after treatment, I'm thinking of that when I'm deciding whether or not to start IO with my chemo, or in the recurrent setting, whether to give chemo versus Lin-Pem or Evroletro or whatever, the other plethora of options that we have. I'm thinking about that all at the beginning, and we're having all these discussions of what are the advantages, disadvantages of this, and with that hazard ratio from the subgroup analysis and everything, my patients are very excited about this as a maintenance option. And once, it's kind of easy to sell. You've got to like kind of step back and tell them like, well, there's some side effects, but once weekly oral versus maybe Len-Pem in perpetuity, or like all of this stuff where they've got to come into the hospital. Once weekly oral is actually a pretty easy sell for maintenance therapy.
Dr. Deska, any thoughts?
Yeah, I mean, I think you said something really important that might have gotten lost, hopefully not. So I think we're pretty sure, but we don't know, and we need to know that IO doesn't work after IO. I mean, we don't really know. And so you said if you give IO up front, maybe you're burning that bridge of Len-Pem later on, and I think that's really important. We think that combining IO with chemo is what makes it work in the PMMR setting, but we don't really know that Len-Pem later is not better. Like sequencing chemotherapy with Len-Pem might be better or equal to giving the IO up front. So I think that's really important. And as we learn more about this, we know Bev works after Bev, but we don't know that IO works after IO. And
Probably doesn't.
Right, it probably doesn't.
Yeah, probably doesn't.
And you're burning a bridge, like you said. And so I think it's very reasonable, particularly in this group, to have that conversation. The one thing that I've had trouble with is the randomization to placebo, which you didn't mention, which in general patients don't love. And then the other thing that I've had some trouble with is diarrhea. I was hoping that you would.
I haven't seen any.
You haven't seen any?
No.
Okay.
I mean, I've seen plenty. I've done a lot of dose reductions, but I haven't seen any diarrhea.
Okay.
Okay. No questions. Okay, let's do a few cases. Oops, I went the wrong direction. Failing. Okay, so we have 3 cases. We'll see what we can get through, because I want to make sure we get to the next session. 4 questions?
We have 4.
4, okay, we'll just do a few. So these are like from our practices. These are real, and then I changed them a little. So this is a 54-year-old. She's got stage 3C2, grade 3. She's measurable disease with PMMR. She's come to your clinic. She's just PMMR. She doesn't have any other biomarkers initially that have been sent. She's coming from another institution, and they've kind of said she's not interested in clinical research, but needs treatment. She has surgery. She gets a CT scan, and in between like her surgery and the post-CT scan, she's now got measurable disease. Like, how often have you seen that, where people just are kind of growing right in front of your eyes? And so she's coming to see you. So I'll start with you, Dr. Deska. She's had surgery on the outside, got referred in to see you at University of Virginia. You get a CAT scan. It's been like 8 weeks from her surgery. Now she's got measurable disease. You can see them there with the arrows kind of in the middle, and needs therapy. And she's PMMR because they did IHC.
Can we take the indeterminate pulmonary nodules off the table?
Yeah.
Do you have a clear that just makes it more complicated.
Okay.
So in our tumor board at the University of Virginia, we will have an argument about whether she should have chemo radiation followed by chemo versus chemo followed by, we call it a puff to the cuff. We use a lot of brachytherapy in a data-free zone, and we call it a puff to the cuff. So, I have to attribute that to Dr. Landon. Stop.
I like that.
So we would have an argument about that. I personally feel like, primarily fueled by my radiation oncologist who still really believes about the role of radiation in this stage 3C2 disease. I do think P53 mutation status matters for 2 reasons. First, if she's P53 mutation positive, then I have more oomph for arguing for 6 cycles of chemotherapy. But also because if she were P53 wild type, if her tumor was P53 wild type, and I'm putting the indeterminate pulmonary nodules back on the radar screen, she may or may not be eligible for a trial. So, yes.
Let's say we think the let's say she's recurred, she's got big parodic node, she's got pulmonary nodules.
Oh, yeah, okay. Well, then she would definitely matter because she would be eligible for the trial that you were talking about, which we have open at my site.
And Dr. Jordan, we've talked about with Dr. Weston's study, the role of PARP inhibitors. So she's PMMR. So are you going to do Taxol carbo followed by durva olaparib? What makes you look at that regimen versus Siendo? Because that's two options now, not on label, neither on label.
Not on
So we can say that.
Yeah, well, that's what that was going to be my response to the PARP is I mean, I think that regimen's not ready for prime time, and it didn't get. I think that there may be a subgroup where that is, and we talked about PD-L1 as potentially being a signal in the DUO-E, which we had open to, but I don't think it's quite ready for prime time. I haven't given anybody that regimen off protocol. I was hoping Dr. Duska would get the PARP question, that I would get the P53 mutated one, but I'm not ready for PARP and endometrial cancer. I don't really see the huge benefit there for a potential big bone marrow toxicity hit later on in treatment too.
So I think this is the place where you would want to do it if you were going to, but I'm not sure I could get it paid for. And many of my patients are underinsured or uninsured in any case, so I don't feel like it's something that I could do right now for that reason.
So in the future, let's assume that olaparib durva gets approved for PMMR, and let's assume that Selinexor gets approved for TP53 wild type. So you have both options for patients.
We're not doing cross-trial comparisons.
I know.
No, I'm
We
kidding.
have two. You have two. Yeah, we're not.
Yeah.
How would you
I don't
consider those two things? Like, what would be important between those two options in picking for your patient?
For me, it would come down to P53 status. If she was P53 mutated, I'd be pushed towards IO, and then with consideration of adding PARP. But if she's wild type, I think from the Ruby data, and I would much rather give her that chance at knowing that she's PMMR, P53 wild type, then she's going to be in that group with a potential like 30+ month PFS advantage.
Yeah, so maybe cross-trial comparisons, but maybe magnitude of benefit too. What about, so there's so many things, we could spend the whole time on this case.
Yes, we could.
So I'm going to just pick one of these case modifications. What if she's, so hard. What if she is, let's take the pulmonary nodules back off the table. So she's presenting, she's 3C1, we can make her 3C2, and you've resected her. She's now non-measurable. So she's come to you at your clinic, she had her surgery a few weeks ago, you're like, let's get a CAT scan, not measurable, but advanced disease, 3C2. What do you need?
PMMR or DMMR?
I don't know, you're gonna order some testing?
I mean, always. I mean, by the time I guess if somebody else operated on her, I wouldn't necessarily have the testing. Well, but I'd want to know my MMR status for sure for B21, because if she's PMMR, she's again in that group that we might not be benefiting her and potentially hurting her later on by giving her IO now that it's not. And we had talked about earlier. I wanted to clarify. I'm not one of those people that like, oh, I want to save this for later on. I want to cure them in the front line, but if it's not going to benefit, then potentially I am really hurting them later on by burning the IO bridge early.
Yeah. Would she be eligible for export?
No.
Yeah. Kind of feels like she should be, but she's not.
I was going to
I
say,
wish.
I don't know what the practice is of everybody in the room, and I don't send NGS on all my endometrial cancers, although one could make an argument for doing that. In the case of the stage 3 and 4s and the high-risk histologies, I sometimes would lean towards sending NGS at this point, just to see what other options are available for that patient.
What testing do your pathologists do just reflex at baseline? Like, what are you getting before you even consider sending NGS?
We argue a lot about that, but we do HER2, MMR, P53, and then POLE we do not. But then after that, I think the rest, and to Katie's point, Dr. Moore's point, IHC and NGS are two completely different things. And we all need to recognize that and make sure we're all speaking the same language when we say those things. And thank you for making me clarify what I meant by that.
So this is the second case. This is a 3C2 uterine serous carcinoma. You can see her molecular biomarkers here. She's pMMR, as most of them are. She's HER2 plus meaning positive, and TP53 mutated. So she had surgery in December of 23, got paclitaxel carboplatin, and per the NCCN guidelines went on trastuzumab for 6 cycles and gets her like first CT post chemo, like heading into her trastuzumab maintenance, and unfortunately has a measurable right external iliac node and new bone mets, which are a little bit hard to see on this scan, but they're there, believe me. So, so here she is. She's had 1 line of therapy for adjuvant therapy because she was a 3C2. She's just over 6 months from her chemo, trastuzumab, and is presenting with metastatic disease. So what are your treatment considerations for her here? We'll start with you, Dr. Duska.
I'm starting with me again? Okay.
Oh, sorry. I didn't
No,
realize.
it's okay. So I'm assuming I'm allowed to think about palliative radiation to her T8 bony met, right? I mean, we're not talking about that, but I would think about that. I would not give her paclitaxel and carboplatin again, given that very short interval. And we talk about the platinum-free interval in endometrial cancer like it's the same as ovarian cancer, but it's not, and I just really don't think that that's, but anyway, this is a very short interval, so it's irrelevant. She would be a candidate for TDXD, which is effective even after trastuzumab, so I would think about that. She is a candidate for a WEE1 inhibitor study that we have open at my site, maybe for not too much longer because I think it's closing soon. She would be a candidate for Len-Pem. So she has a lot of different options. I think it would depend on, she's 73. I think I would also take into account her performance status, her underlying toxicities. If she's in a nursing home, obviously I'm not going to go crazy on this one. So taking the patient into account, if she has taking her bone marrow status into account and her underlying toxicity from her prior therapy, that would help guide me in my next treatment decision.
So Dr. Jordan, so I'm going to change a little bit and say she's made it 9 months. She's had a 9-month Taxol carbo for 6 cycles, and then she went 3 more months. She went 6 months off. Let's give her that.
Was she on maintenance?
Maintenance trastuzumab.
Okay.
She makes it to 6 or 7 months there. So now she's recurred. Still pretty quick.
Yes.
You know, she's recurred 7 months after Taxol carbo. Same molecular profile. What drives you to use, because Ruby allowed this, right? Taxol carbo durva, or dostarlimab, sorry. That was allowed. You just had to have 6 months. What makes you go for that FDA-approved medication versus TDXD versus Len-Pem that has an OS advantage? You know, phase 3 study, Len-Pem, OS. Does the HER2 just, is it like this shiny penny that we're all like, or is there some rationale to how we're going to sequence medicines for this patient?
Well, sorry. I'm like really cautious about the shiny penny thing because I have this patient right now that this exact patient that her end of treatment scan after GY026, arm 3, was progression. I'm like, great, now what do I do? I don't know the answer. I know it does work to give TDXD after trastuzumab, but immediately after, I don't know. Do we know that? I don't know. My sense is that maybe we take a break at that biomarker, and so what I'm giving that patient is Len-Pem, and I think even 6 months later, I think I would still go towards Len-Pem rather than Ruby. And then I know that in heavily pretreated HER2-positive patients, that Enhertu is still going to work later on, that I can, TDXD, sorry, that I've still got that on the table. But Dr. Duska brought up a great point about ECOG status, and if she's maybe, I would favor side effect profile maybe of TDXD over LinPim in a less robust patient, but I still don't penalize patients for LinPim. I think you can still help them out with dose reductions and things like that. You can still get them through it.
The other thing to remember, and I know everybody in the room knows this, is the Destiny Pan-Tumor 2 trial only had 40 patients in each cohort. So we really need more data to figure this out. It's really exciting data, I think, especially in endometrial cancer, which did better than any of the other cohorts. But still, there were only 40 patients in that cohort, so it's really great that we're doing a next Destiny trial in endometrial cancer, which hopefully everybody is working on getting open also. At my site, we're getting ready to open it because I think we really need to learn more and we need more patients.
It's really into the biomarker. What's the predictive value of a 2+ versus a 3+ versus a 1+?
1+.
Yeah,
Right.
we just really
Yeah.
don't.
The other
Yeah.
thing is, I don't know about everybody else, but I have to fight with my pathologist because for trastuzumab, you need breast criteria for HER2, and for TDXD, you need gastric, and they don't love having to give me 2, and they don't love me telling them what I want, so sometimes there's a little back and forth about that.
And then I think the other thing to talk about, and let's go to the next case, is, this is a patient who got chemotherapy for adjuvant, so never got it for metastatic. And so when, how, you said you might go to LenPem, and is that just sort of what were you persuaded by the subset analysis from LEAP-01, which was LenPem versus Taxol Carbo, which I actually must say, I thought that was gonna be positive, and I was wrong.
Right.
Definitely wrong. But the prior adjuvant subset actually did look better with LenPem, and it's a subset, and we have to be very careful, but it looked good, and that's really on label, it's second line.
Yeah.
Right, so it made me rethink my strategy, because I was sort of a retreater to chemo, and then I went to LenPem, but now I'm kind of rethinking that. How do you, what makes you retreat? What makes you retreat her with paclitaxel, carboplatin, IO rather than LenPem? Anything?
Well,
Which is okay to say nothing.
I say nothing.
Yeah,
I
that's
think
fine.
they have a lot of neurotoxicity from the first
yeah.
line of paclitaxel carboplatin, and they really don't want to lose their hair again. And yeah, unless there was a really long time between the first one and the second one, I probably wouldn't even think about it right at that moment.
So, it might be a good time to bring up inclusion criteria, though, too. If she were P53 wild type, and she's serous, so, she's mutated. But if she were wild type, then that is a real thought you have to have of, am I going to put this patient on export, or am I going towards Selinexor with a response to platinum-based chemo, or am I going to go down the IO route? And even though it's a maintenance trial, you have to make that decision kind of early, which does force you to think about that. But I think LEAP reaffirmed my practice in using LenPem in second line.
Yeah. I think one of the interesting things that we don't have an answer to is, so I love ADCs. I'm going to just acknowledge my bias, so I probably would have used TDXD, or we have a trial with a different drug. I would have used that. But I do wonder, because in melanoma, which we're not melanoma, there was a dream-seq in BRAF mutated melanoma, and it was vemurafenib and a MEK versus Ipi/Nivo. And I was like, well, of course the targeted therapy is going to be better. And it was a sequencing study. So they started with Ipi/Nivo and then went to the BRAF for BRAF and then Ipi/Nivo. And the Ipi/Nivo first did better, markedly better, even in a biomarker positive. And it's a different sort of disease and question, but it just it always sticks in my brain because, it was published last year, because it just shows that when you have more than one good drug, you really need to figure out, the order may really matter in terms of how long you quilt together this survival for your patient. And we've never had a number of good drugs to even worry about sequencing.
It's a good problem to have.
It's a good problem to have, yeah. And I don't know what the answer is going to be.
But
Okay.
I also think thinking about your patient's underlying toxicities is really important, because there's some things you can just cross off the list. If they can't feel their feet, you're not going to give them Taxol Platinum again.
Right.
Right? So,
Yeah. They get pneumonitis on their IO, they're not going to get other things. So.
right.
Right.
Okay, so this is an 82-year-old. She's a little bit older. She's TP53 wild type, grade 2 to 3, kind of a mixed pattern, endometrial cancer, She was diagnosed back in 2017, got surgery, did really well, kind of out in the world living her life. You know, it's been 8 years, and comes in with a swollen leg, unfortunately. And so gets scanned and has new kind of pelvic sidewall disease on the right that's causing hydro, and she has new lung nodules. So this is more than just local recurrence. And we're really looking at, you know, 7 to 8 years after her initial diagnosis. So it's rebiopsied because you're like, what is this? It's kind of weird to recur this late. And it's all the same thing. So what are your thoughts for her? You have her initial histology from 2017. Kind of what are we thinking about here and working her up? I'll start with you, Scott.
I think that's the same question that I got ahead, and I talked about wild type with the last patient, but this is the, I think this is a long enough, and I don't know what my number is, but this is a long enough disease-free interval where I'd be like, well,
I would.
I mean, and she didn't get treated with systemic therapy before. She's totally chemo naive, so I think this is a great patient who needs systemic therapy with carbotaxol. I mean, I think this one's pretty straightforward in that regard. But had she gotten chemo in the past, even, I would still probably go back to chemo.
Well, but then the question is, are you going to add IO? Are you going to add IO plus PARP if those drugs were free?
If they were not in the wild type patient, because of the Ruby, I'm going to lean on the hypothesis generating subgroup analysis from Ruby, and then I'm thinking about my trials that I've got open, and she's an export candidate here.
Yeah, she's an expert. So she's HER2 1+, TP53 wild type,
PMMR.
ER positive, PMMR on your next-gen sequencing that you sent. So she would be, all of those things are going to be options, right? We could have chemo followed by Selinexor. We could have chemo durva followed by durva-olaparib.
Yep.
You could just do chemo IO. All of these are likely going to be on label for us.
Yeah.
But really sort of figuring out magnitude of benefit for her is going to be sort of our next good opportunity. We're going to have 3 ways to treat.
Yep.
So again, good problem to have. All right, last case.
No, this one has
This one has more.
it has more.
See? Oop, okay. Well, I kind of jumped in. So she got 6 cycles of
I don't know.
carbotaxol.
We can already talk about it, but
We
We
already
kind
talked
of
about
so she's
this, yeah.
enrolled. Okay. So, but it is a good opportunity to discuss again. So she's on export. She was enrolled last year, and she needed 2 dose reductions. Was this your patient?
yeah.
Yeah. So, kind of take me through kind of how she presented and how you managed that.
She's when I met her, she was 80 and had a great performance status. Worked out every day, and totally independent. She wanted to be aggressive, and that's what we talked about. Now, as soon as she started, when she did her first cycle on drugs, she was in bed for 2 weeks. It couldn't come in for her like interim even visit because she was like completely debilitated, didn't eat for 2 weeks, and you can see from the CT, she's not a big lady. She didn't have a lot of nutritional reserve. So the nausea and vomiting really hit her hard. We dose reduced her, and then we finally were able to add the Akenzio, and it, I mean, she perked right up. She did really amazing. She's back to working out. She has a great quality of life, independent living, and she's done really well.
So it's cycle 17,
It's 18 next week.
cycle 18 next week.
Wow.
That's pretty
okay.
amazing. Like,
Yeah, one of my sub-bites has to see her because I'm getting surgery. So.
yeah. But I mean, it is, I don't know, there may be younger people in the room, but I mean, Linda and I remember these patients who presented with recurrent disease, their median overall survival was,
6 months to a year.
a year.
Yeah.
Well,
We
we
had
didn't
12
have
to 18
anything
months.
to give them back then.
We have carbotaxol, and then we had adriamycin.
Right,
and some
that's it.
endocrine therapy.
Yep.
This is what people had a 30% likelihood of having 12-month OS when I started as a faculty member. So it's just amazing. It's kind of like, it's like ADCs and these IOs. It's kind of the closest thing you see to a miracle, I think, in medicine sometimes.
But
So-
now we just need to fix the disparities problem. But we really need to reach out to those populations that are not benefiting from these treatments and see how we can fix that.
All right,
We're out
last
of- we're out
case.
of time.
Hmm?
We have 1 more minute.
1 minute. Okay, last case. So recurrent stage 1B. She's PMMR. You don't have any other biomarkers because she's just been referred to you. She has 1B, so she gets surgery, give her paclitaxel carboplatin for 6 because she's high-grade serous, so she gets 6 cycles, and she goes 9 months, and then comes in with this cough, and here's her CT scan, so you can see the new pulmonary nodules, even if you're not a radiologist, but she's also got carcinomatosis in her abdomen, so she's sick. You rebiopsy this like peripheral node out here, nodule, because it's on the periphery, so you can get a new specimen. Confirms recurrent endometrial cancer, HER2 1+ by IHC. And historically, she's, kind of declined participation in trials. So what, really quickly, this is our last minute, either one of you, sort of how are you going to approach counseling her and taking care of this person who's
Well, can I
presenting?
address the historically
Yes.
disinterested part? So I offer every single patient I see a trial if I have a trial for her. And I tell them, it's okay if you don't want to do this one, I will offer you another one later on. And so I would always offer, regardless of whether she's declined in the past, just to make sure that she is making an informed decision and that she knows all of her opportunities. So I would encourage people, even in this setting where somebody has said, I'm disinterested, to continue to offer, because at some point they may change their minds, or even explore why they're disinterested. So I would put a plug in for that.
Yeah, I think that's why I just wanted to get to this one. And I'm just really embarrassed that I can't remember the physician who gave that excellent talk in the opening.
It was Kaylee Underkoffler.
Thank you.
You're welcome.
So that was a great talk. And it just reminds us, patients, maybe just that we get this it's in the charts all the time, patient not interested in trials. And then you walk in and you're like, well, I have standard of care, I have these trials, this is really interesting, and this is why. And if I show interest, her point was exactly it. If I'm interested and I think it's promising, I'm not going to offer you something I don't open things I'm not interested in.
Right.
I only open things I think might help people. And they don't always work, but I'm always interested in the science. Sometimes patients, they just like having a choice, and they can
Right.
choose standard of care. But a lot of times they're like, oh, well, if you're excited about it, that I'm interested in it, I want to hear more. So I think just making sure we kind of keep that. I thought it was just such a good message that I just wanted to bring that up. I think we've talked about a lot of
Physician
these.
bias is a big problem in accrual. It's
Yeah.
not just the patients, it's us, and it's not just us. It's their primary care physicians and their community oncologists who might have sent them in to us. They have the bias against it, they're not going to do it.
Yeah.
So,
And it's especially true, you brought up the point, and we're going to end for export, that patients, they really generally don't like it when they're randomization to placebo. And so and I don't either. I'm just going to say I don't like either.
that's
So
true.
if I walk in and I'm like, well, I don't like it because you're going to get randomized to placebo, they're not going to go on. So we have to sort of put our biases aside with some of these, because we're not going to get answers to these important questions unless we get the studies done, even if we don't necessarily agree with all of the elements. So I'm as guilty of that as anyone. So, all right, we're done. Okay, thank you so much, everybody. Thank you for joining us today. I hope this was informative. Please go to the last session and support our speakers. There's some excellent presentations, and safe travels home.